disease. So that could be where there's only one mutation and it's inherited from the dad, or there are no mutations at all. In that case, the standard of care is becoming do a PET scan. If the PET scan is diffuse or focal, then that changes how you do your surgery. Now, in the old days as well, the other thing we used to do before, when we were doing the ASVS and we didn't know exactly where the lesion was, we would take biopsies and take small parts of the pancreas out till you find the lesion. So places who don't have a PET scanner, but people like us who have a histologist who knows what he's looking for, that we'll do that as a last resort. So for example, in Texas, Medicaid won't allow a patient to be transported out of state. And so Medicaid includes like TRICARE and the managed Medicaids. And so they refuse to allow a patient to be transported out of state. So if we have a patient who might be focal disease, then we'll do a very slow pancreatectomy. It can take us up to 10 hours, taking little by little out till we find the lesion. So there is an advantage even coming to a center that can do that if they don't have a PET scan. So you've got the top level, which is CHOP at the moment, that can do everything. Then you've got us who don't have our PET scanner but have the multidisciplinary team. Then you've got really good pediatric endocrinologists who know a lot about this disease but just don't have quite that experience. And then you've got your sort of average endocrinologist who knows what it is, can make the diagnosis and will transfer the patient. So there are lots of different levels of endocrinologists out there, and each one has a very important role because not everyone has to go to the major center. And that's important to know that. Lots of babies with transient who respond to diazoxide, lots of patients who are diazoxide responsive, they don't need to come to the major centers. Now if there's one an hour away, it's a great help. But you don't have to fly to Philadelphia if you're doing great on diazoxide.
Okay. Do you want to take a short break?
Yep. One last question? Or two. We've got two last questions, then we'll take a short break.
Is there any ongoing research for children that have diffuse, that have not had surgery, and how they're doing? Because I know that we have connected to a mom that has a 16 and a 14-year-old. She refused to have the surgery, and she said by age 6 or 7, it almost, as she stopped having problems with low blood sugar, it almost went into
right. So there's a group in Israel who believe that they can manage the diffuse disease throughout those first 5 to 6 years, avoid hypoglycemia, and then when the kids get to be anywhere from 4 to 8 or 9 onwards, life becomes easier. Now, as you will know, life becoming easier might mean I can go 4 hours without a low blood sugar. Yeah, so some other people would say, oh my God, that's horrible, 4 hours and you're going low. And people who have been through the half hour and going low will say 4 hours is easier. So you do not get rid, genetic diseases don't go away, but they may become easier to manage because the patient gets bigger, the amount of glucose that you need per minute in your body gets relatively smaller, so it's easier to eat that amount of glucose. And most importantly is that the brain has finished growing and developing by 5 years of age. So if you're 6 months of age and your blood sugar is 35 for an hour, that can cause a lot of damage. If you're 15 years of age and your blood sugar drops down to 35, A, it's happening as the child, so they can do something about it themselves, and B, it's less likely to cause damage. So for example, that type 1 diabetes is very, very common, and people with diabetes will often have low blood sugars, 2 to 3 low blood sugars a week, and they're not all brain damaged. And in fact, it's very rare that they are. Now they can be, and people can die of hypoglycemia, especially if it happens during the night when they're asleep and they can't tell. But it becomes less serious to have hypoglycemia the older you get. Hence, the people who have diffuse disease, who haven't been operated on, whose children are older, they can recognize the symptoms, they can intervene on their own without doing a blood sugar test, and they're able to go longer and longer, and if they make a mistake, the consequences are less severe. That is why they say it gets easier to manage. But it doesn't go away. And so yes, there is a lot of research, and one of the things that we're looking at in our institution is outcomes, looking at neurological outcomes, that patients with focal disease treated, patients with diffuse disease with surgery, no surgery, looking at all those different things. So people like you who haven't had surgery with diffuse disease are somewhat rare in the United States. And it would be very important to be participating in some of those studies. So let's look at it and see, because let's say it turns out that we can manage a diffuse disease patient with no surgery and get them to 6 years of age, and the outcome is exactly the same as doing surgery. That would be very important information. Let's say it turns out that sadly it's not as good, then that also would be very important information, because a family like you is sitting down with a surgeon hearing about 98% pancreatectomy, the risks of infection, of bleeding, of pancreatic cyst, of liver damage because of the gallbladder, and all sorts of different things, and you're going, whoa, that's not for me. But if we could say to you, well, there is a 20% chance you'll be brain damaged if we do surgery, and a 30% chance you'll be brain damaged if we don't do surgery, that's another little part that you add into the equation. But we don't know that until we follow. And so, you know, because we've only known about the difference between focal and diffuse since the mid-1990s, and because you really need years and lots of patients, we're only now starting to look at all of the information that suggests, of course, as you'd expect, that people with focal disease who get cured have a less risk of bad outcome than those with diffuse disease who don't get cured. But many of us believe, actually, that when you get in the hands of a good endocrinologist who knows what they're doing, and even though you may have low blood sugars, they're right on top of them and correcting them. We believe most of the damage is usually done prior to the diagnosis and transfer to an endocrine center. Be it your local endocrinologist who may not be very experienced in managing 50 kids, but knows he's got to keep that blood sugar up. Once you get into the hands of an endocrinologist, it's rare that problems are ongoing.
And how do we get into a research study? How?
You call up the people or you come talk to us. So, we rarely advertise in the newspapers. So it's talking to family support groups, talking to other parents, and they'll tell you, hey, I'm doing this or I'm doing that. The real way is to go to centers where they have large numbers of patients, because they're the people who are putting together series and different things. So, for example...
Like you had, I would imagine, you guys Valley.
Yeah.
Well, we're here in Texas. So I guess we would come to you,
Yeah.
right?
So, but do you do the studies?
Yep. So the studies tend to be retrospective studies whereby you start to collect data on patients, you follow them over a period of time, and at the end of the time, you then report, what went on. So, someone like me who's relatively close to you guys, I would be very happy to work with the doctors in Austin. I'd see you maybe once a year. They'd see you all the other times, manage all the little different things. But that way, families like you would stay in the loop of what the latest research is. If the drugs that they're trying out in Philadelphia start to look very promising, they might say to me, we need some help to recruit more patients. Could you become a co-investigator? So sometimes centers will work together. And typically, what will happen is someone will start off on a study, do 15 to 20 kids, see if it's looking promising, and if it's looking promising, then you want to extend it out and do more, and that requires people who've been treated before coming back. So patients who've been treated will often find, and they've gone back out of the original, center like Philadelphia and say gone back to California, that as these studies come back, we might try and contact some of our old patients and say, would you be interested? Because it's so rare that, there just aren't enough kids. And you had one last question?
No.
Okay, it's coffee time.
Yeah, it is.
Or tea time in the UK. Thank you.